Hi, where are you from? What's your name?
My name's Cassley and I'm from Vancouver.
And where are you taking?
I'm currently starting an internship at Harvard Medical School working on a new healthcare innovation project.
So tell us, Cassley, of what you've heard today, what's the most important thing you've learned at the conference?
That's a good question. I really enjoyed the mental health session and talking about mental health in different countries and kind of ethnocentric views about mental health and diagnoses.
Hello, I'm Roberto Nang. I'm a colonel in the U.S. Army and a professor in global health at the Uniformed Services University of the Health Sciences in Bethesda.
So Dr. Nang, you're an expert actually in global health and security issues. Tell us why global health is important in security.
Global health is fundamentally important for security because of a number of reasons. The Department of Defense has realized that in terms of some of the emerging infectious diseases, biosurveillance is a very important issue that we need to be aware of. Collaboration also on emergency medical preparedness between countries is very important, especially when you're dealing with humanitarian assistance and disaster relief. Obviously also in terms of uniformed services and the United Nations, anytime there's unstable regions or fragile states, there's a need to provide sometimes some peacekeeping or peace enforcement issues. And of course there's the CBRNE issues, chemical, biological, radiological, and nuclear events that the Department of Defense has a lot of expertise compared to others who may be involved in global health.
And Dr. Nang, you're running a panel here at the CUGH Conference. Tell us what that's about.
Yes, our panel is entitled the role of the military in terms of the political, legal, humanitarian security challenges in providing humanitarian assistance and disaster relief in semi or non-permissive environments. And so it alludes again to the difficulties encountered in chaotic, unstable, fragile states when it's not just a matter of logistics and the delivery of goods, services, food and water or shelter, but also having to deal with combatants and potentially antagonistic factions that will seek not just to disrupt your humanitarian assistance and disaster relief missions, but also to actually attack the vulnerable populations that are involved.
And conflict prevention, would you say, are neglected global health challenges?
I would agree with that, Dr. Martin. Yes, sir.
Thank you, sir.
My name is Garcia. I am from Lima, Peru, from the Universidad Peruana, Cayetano, Heredia.
And Dr. Garcia, tell us here what's the most important thing you've learned at this conference?
Well, I like the fact that this conference historically is turning really in a more global health conference. I think that when it started, it was really so focused in the United States, but now coming from a developing country, I see the change. However, I have to tell you something. I heard that people are still using this term Global South and Global North, and I don't know if it's a matter of a language, okay, because my main language is Spanish, but I think it's an oxymoron. If we're global, we're global. We're not South or North.
So what you're saying is the problems you see in Peru, you can see in the shadow of Capitol Hill in Washington.
Absolutely, and the solutions that you may have may work for us, or maybe we can have solutions that can work with you, or for your country. So I think we share so many things, and that's the beauty of global health. So thinking how can we all work together to find solutions that we can implement collaboratively and can make the world better.
So do you think that we can do a better job of transferring knowledge, not only from the north to the south, but importantly, south to the north and south-south?
Absolutely. So we have to think on all and making collaborations all over. So at some point, one of my wishes is that we should not keep talking about south and north. It's just global.
So Dr. Velarde, tell us how we can collaborate more effectively together. You're the president of Cayetano University in Peru. How can we collaborate more effectively?
Well, as you have listened, as we have collaborated in different levels, research and training and building capacities is the most important kind of collaboration. But I think we should strengthen the communication by the technology of information. I think with TICs, within an important future. So it will be nice if we can have a network of people engaged with different global problems, global diseases, but with different disciplines. Because when we participate with this technology of information and we take we talk together in conference or whatever. Usually it's medical doctors with nurses and nurses, but I think it would be nice to have roundtables and to be more active with e-learning in different topics and different disciplines.
And how can we do a better job of translating the knowledge that's produced into impact to help those who are least privileged in the world?
Well, with these technologies, I think we have an enormous opportunity to get directly to our universities and work together in all these topics. So I think much more than well, we have to have leaders in our universities which work with leaders in the universities in US and with these global health leaders and work together in order to cope one problem, but with a long-standing collaboration. One problem also that we have seen is that sometimes we have a collaboration for 4 or 5 years, for example, but the really ones that have made a difference are the long-standing collaboration, because once our leaders have built their capacities, they translate this capacity for other leaders in their communities or in the regions where they are, and even in the region, if we are talking of, for example, Peru, the Andean region.
I'm Kamini Valley, Mahabal, and I'm from Bombay, India. I work on the issues of gender, health, and human rights, and I'm an independent trainer there, involved with various movements of health and gender.
Why don't you tell me what really inspired you or angered you at this last session?
What angered me was we are talking about the planet and the civilization, and we had great panelists there, but no representation from Global South or a woman. We hold the half of the sky, which is the 50% of the population, and there was no voice there, which angered me. And I'm happy now because I'm going to start with a session which is an all-women panel of Global South voices on the issues of women's health. We are going to have voice from South Africa, from Sudan, from India, how the women are actually working towards survival, especially in the context of gender-based violence. Another thing which has angered me is that the violence against women plenary is at the end. Nobody's going to be there. I wish it was now, and this plenary could have been tomorrow, and the awards giving could have been the closing ceremony, because this to me plenary looks like a tokenism. Who's going to be there at the end of any conference? People leave. So yeah, but it's a start, and I hope CUGH in the next conference has many parallel sessions on women's health, has many sessions on Global South and the voices from therein, and just not North America and USA.
What was something that you liked about this panel? Like what was one thing that you're taking away?
Oh yes, the thing, science has to be political. You cannot divorce politics from health or from science, and it has to be the linkages. If we want to see any change within the social system or the health system, you have to have a dialogue with the political system. And if you don't have a dialogue with the political system, you're in isolation like a pretty institute doing everything fine. Yeah, you know, so that's the thing I liked about it. Yeah.
Hi, I'm Laura McKelleg. I'm originally from South Africa. I'm currently an undergrad student at Dartmouth, doing an internship in DC with Susan Blumenthal.
Fantastic. Laura, tell us what you like the most about the conference.
Well, to be honest, the panels are great, so I'm learning a lot there, but it's the combination of learning a lot from the panels and then in between sessions, meeting all these amazing, very smart, intelligent people, having great conversations, continuing the conversation that we witnessed on the panel in real life, and meeting a great variety of people.
And you've been, coming from Africa, you've seen a lot of issues combined. You have a personal interest in combating corruption as a major global health challenge. Tell us how important corruption is in global health.
Well, personally, I see corruption as the one major factor that is just prohibiting us from getting anywhere in global health. So we've made tremendous progress in a variety of issues, but it's the issue where you get given money and it has potential to go great lengths, but half of it's taken in corruption. It's just lost somewhere along the way. So I think that corruption's a huge barrier for us to make progress, and it's a hard thing, and people, it's like an elephant in the room. People don't want to discuss it. So it's just a hard thing to address, as well as like addressing these issues. So we're having the solutions, then it's hard to implement the solutions that we're coming up with because of corruption.
Amy Hagopian, I'm on the faculty at the University of Washington.
And what was your question to this panel, and what did you think of the response?
I asked about how important it is to people that we elevate the issue of war to be a major public health problem. We talk a lot about public health problems that are caused by microbes and human behavior. So all of us are against malaria and leukemia, and we're against car crashes and cigarette smoking, but we haven't yet elevated war to the level of discussion that we need to be having about it. It's an entirely preventable public health problem caused by human beings.
What did you think of the response, especially from Horton?
So Richard Horton gave an excellent response, defending the work of my colleagues who have attempted to study the health effects of war. It's a very hard thing to study because there are no financial supports for it. So the people who try to estimate mortality associated with armed conflict are doing it as volunteers. Unfortunately, the CDC respondent on the panel, in my follow-up with him afterwards, was not able to identify any interested sources of funding for this sort of work.
Well, what did Horton say?
Well, Horton talked about my colleague who had done some of the initial work to identify the mortality number in Iraq subsequent to the U.S. invasion and occupation in 2003, and how his university caved basically to donors in suspending his ability to be a principal investigator.
Where are you from?
I'm Dr. Nils DeLair. I'm the Assistant Secretary for Global Affairs at the U.S. Department of Health and Human Services.
Dr. DeLair, tell us what your views are on a right to health.
Well, my views on the right to health are what the President's views are. He has explicitly said that there is a right to health. It is reflected, although imperfectly, in the Affordable Care Act. And it's certainly being reflected very clearly in the work that the United States is doing in venues such as the World Health Organization and the United Nations. Obviously, the right to health is one that is a progressive realization. It's not something that we can put in place immediately, but we believe that ultimately, if the world is going to become both healthy and equitable, it has to be based on a rights approach.
Will it be, do you think it'll be in the Sustainable Development Goals?
I would suspect it won't, but I'm not certain. That's all part of an international negotiation. I would be pleased if it were, but I think it's going to be a challenge.
King Holmes from the University of Washington.
So Dr. Holmes, you're one of the founders of CUGH. What did you like the best about this conference?
I thought this conference was the most exciting and interesting. As the organization of the CUGH has matured, the meetings have gotten better and better. I think the two things I liked the best, I guess, were number one and two, the students and the junior faculty who are here, who really want to be more engaged in the consortium. I think the students, we need to find a way to involve them to a greater extent. They just were coming up to me and saying, we love this is the most inspiring meeting we've ever attended, and they have so much that they want to give, and they have the energy, and they are the future. And for the junior faculty, it's more or less the same. You know, we have the board members who are all, I won't say all, but generally fairly senior, and it would be great to figure out a way to involve the junior faculty to a greater extent in our programs, particularly in the science that we present at these meetings, which has been has been increasing substantially each meeting, and I think will continue to do so. And it's really as I think Richard Horton said, it's the junior faculty who are presenting the science of global health that are making this the meeting that really is really good.
What's your one hope for global health in the future?
Well, I don't think I have just one hope for global health. You're asking me a question that is like, how do we brand the movement. And I think there are so many components of it. I've tried and I can't think of a way to brand it. I think that we have to make it stronger and stronger. And that means we have a great education working group that is trying to define the core competencies. And we have to both communicate the importance of global health justice and equity, but we also have to give our students and junior faculty the tools to actually make a difference in global health. Whether that's knowing how to analyze local needs, doing needs assessments, working on the kinds of epidemiology and clinical skills, health systems development that are needed, forming stronger partnerships. I would love to see that as the membership of CUGH grows, we have a much larger number of smaller schools from the U.S. that have relatively small programs, but particularly partner institutions from other countries. What do we have now? I think we have 34 partners from other countries. I would like us to have 500 partners from other countries. Those are the people we're trying to work with. And these will be predominantly universities, but medical centers, international agencies that are predominantly working in low-income countries. I think that is what's going to continue to make this a vital organization that makes a bigger and bigger difference and has a bigger impact in global health.
Well, it has been a great opportunity, both in terms of the content and the subjects covered during the conference, as well as the format. I think it was lively, was interactive. We all had the opportunity to express our interest. I think the dialogues or the debates, you call it, was very good, but also the questions from the audience facing the people, the presentators.
Mm-hmm. Dr. Soliman, you're from Chile.
Yeah.
What can we do the next time that would be even better?
Well, I had the opportunity to be at the panel saying what we are doing in global health in the academic institutions in Latin America. It's a field which is under construction. An increasing interest from academic institutions in the region, and one thing I want to stress is that I see CUGH, with whom I have had a several year relationship, that you are getting more interested, and there are real possibilities to interact, to collaborate, and even our academic institutions to become members of CUGH. And this is a two-way path. Yes. It's a two-way path because there are things to learn that we have to learn, but I think there is also for the more developed countries also to learn from what is our experience, you see. And at ALASAG, which is the Latin American Alliance for Global Health, which I head at this time, there are issues that are very specific for Latin America, for, I would say, mostly middle-income countries, which is the majority in Latin America. And there, I think we could build an agenda which will be of mutual interest for both, for you here in the United States, Canada, Europe, and us in the South, and in this case, Latin America. Inequity, and the determinant factors of those inequity in health are those determinants in which we are mostly interested, looking as much as we can to those factors which generate the problems, you see.
Fantastic. Dr. Soliman, it's so good to see you here.
It has been a pleasure for me, Keith, and we will continue in touch.
Fantastic.
Mucho gusto y saludos a todos.
Gracias.